or even with peers from other countries. Finally, we like to make learning fun, and so we bring elements of animation and games into our content and learning designs.
And with this, we have the ambition of being able to reach
Greetings all. So we, since it's been already on time we are, so it's hard to, now we are just starting the session. I'll just put my screen. Just give me a sec. Yeah, so thank you everyone for your attendance today for the webinar. This webinar, Empower School of Health, is organizing in collaboration with PHASOM, that is Pharmaceutical Society of Malawi. And this is our third event together since we partner with them. And today's webinar will be focused on applying the concept of supply chain resilience. And for today's speakers, I would like to welcome Mr. Joe Kalani. He is the Director of Operations Partners in Health. Professor Andy, he's a Director of Training and Capacity Building at Power School of Health. And unfortunately, our moderator patient, she is engaged with some other tasks, so she couldn't join. So I'll be replacing her and I'll do the moderation. If she joins in between, we will chip her in. And also, this webinar will be recorded and it will be shared with you all. You all will be getting a certificate of participation. The link will be posted on the chat box. So there is a form which you need to fill up, and the certificate will be sent to your registered email ID, which is registered with Zoom. Also, the slide deck, which is presenting over here right now, that will also be shared with you all on the email itself. So now we will be just moving forward. This will be the agenda and flow for the webinar, as you can see over here. So let's move on to the next slide. There are a few housekeeping announcements. For participants, kindly mute your mic and turn off your videos. Please ask questions using the chat box. I would request please be attentive during the presentation of the speakers. If you have any questions, please put it in the chat box. I would request backend team, please mute other people as they can unmute themselves. Yeah, so okay, so all of the questions will be addressed during the Q&A session. At the last of the, there are 10 to 15 minutes that has been allocated, and we will try to answer as many questions as we can during the allocated time. There will be 2 polls, so I would request all participants, please participate in the polls also. And as informed to you all, webinar recordings will be available in Power School of Health YouTube channel. And also the link will be shared with you. The slide deck will be shared with you, and please participate in the poll also. This next, this slide is for our speakers. Please turn on your cameras whenever you are speaking for the better engagement. Please mute your microphone when other speaker is speaking. Please adhere to the webinar schedule timing. As informed in the beginning, the main objective of the webinar is to deliver and explain about applying the concept of supply chain resilience. Now this is the time to launch poll 1. I would request my backend team to please launch poll 1. And I would request all participants to please participate in this poll. These are the basic generic questions which help us to know you better. So the first question is, what is your gender? What is your age group? What is the geographical region are you from? What is your academic background, and about your work experience? So we will wait for a few seconds and then we will show the results to all of you. Your participation is needed. Please select the respective answers. You just need to select the option in front of the question, and your survey will be submitted to us. Also, I would request my backend team to please admit the people who are waiting on the waiting room. %54% of participants have participated. I would request others to please also quickly do it, so we will move forward to the other slides. %70% as of now. 30% more, please do it. We will wait for a few more seconds and then we will close the poll. And also do not forget to collect your certificate by filling up the form. The link will be posted at the end of this webinar. Now I would request the technical team to please stop the poll and show the results to us. Okay, so as I can see over here, the majority of the people over here, 65%, those are male, 35% are female. The majority of the people are from age group above 30. The geographical region, which I can see over here, 16%, that is Malawi, and 47% others. Okay. The academic background, I can see majority are from pharmacy bachelor degree. And the years of experience, the most of the people have more than 5 years of experience. Thank you so much for your participation. Now we will move on to other slides. Now, my name is Sonia, and I'm a part of Empower family from last 4 years now. So I am actually into a process where we reach out to different universities, colleges, associations for the collaboration. And this activity is one of the collaboration activity that we are organizing with PHASOM, with whom we have partnered last year. So I'll just give you a brief information about Empower School of Health. For more information, you can visit our website. So Empower School of Health is a capacity building organization and has worked over 100 countries across multiple languages to strengthen the institutional and HR capacity of global health and humanitarian program through digital learning interventions. Our reach has already been reached out to 1 million hours, deliver nearly 1 million hours of capacity building content to nearly 200,000 public health professionals globally. As you can see, we have 3 focus areas: leadership and change management, digital learning, public health procurement, and supply chain. And on the bottom, you can see the domain areas. Those are 5. The slide deck will be shared with you all, so you can have more information about it. As I have just explained that we are also partnering with other universities, other societies, councils, and institutions. So this is not the updated one. Actually, we have few more collaborations, but this will give you a brief idea that with how many universities, institutes we have collaborated so far. You can see in Malawi, we have partnered with PHASOM, and there are a few more conversations going on, so we will be soon partnering with other. And also, as per academia, we have recently partnered with UNITA for our master's and PGT course. So as you can, this slide will give you a brief information about our advisors and faculty. Professor Paul Lalwani, he is the Director Empower Group, former Head of Global Fund, Procurement and Supply Chain Division. Professor Andy, he is also a speaker for today's event. Now, I would like to welcome Professor Andy. And Professor Andy, I would be glad if you can just give us a brief information about yourself and you can continue with your presentation. Thank you all.
Greetings and welcome to all. I think many are familiar with my voice already from the course. I'm one of the co-authors of the Yellow Book, Managing Access to Medicines and Health Technologies, MDS. I've been working in this field for over 30 years, and I'm still singing pretty much the same songs that we were 30 years ago as we try to modernize public health supply chain. I've worked in many countries. It's a long time since I was in Malawi, but I still remember that quite well. And most recently, I authored the supply chain response for COVID-19 for WHO and the GOAN, the Global Outbreak and Alert Response Network with WHO. So let's go to the next slide and on to today, please. Okay, so today I want to try and talk about supply chain resilience and exactly what we mean by this resilience and why it's so important and what we can do about it. We go to the next slide, please. So firstly, what do we mean by supply chain resilience? And it's the ability of the supply chain to withstand disruptions. Many of our supply chains already have some resilience. Most of us are familiar with the concept of buffer stock. If there's a delay in supply, we've still got some buffer stock we can manage. That's a form of resilience. Unfortunately, for many of our supply chains, that's the only form of resilience we've got. And we need to move far beyond this passive resilience into an area where supply chains are agile. Not only can they recover from a shock, but they can predict, they can forecast, they can anticipate a situation that might be a problem and work on mitigating it, reducing it before it happens. And we call this kind of approach risk management. So we have to move beyond this passive resilience of just having some buffer stock into being able to predict disruptions and being ready and prepared for them when they arise. Next slide, please. Let's firstly understand that before COVID hit us, our supply chains were often already in a very poor state. We look at the reports from many bodies, but especially from UNDP and UN in general, that we're failing to get supplies to the patients. Even when we have the money, even when we have the stock, we're not getting the supplies to where they're needed. It's not happening. We're failing to meet the Sustainable Development Goals. We've already failed to meet the Millennium Development Goals. We're now failing to meet the Sustainable Development Goals. And one of the reasons for that is our supply chains are performing so poorly. If we had better supply chains, we could save 6 million lives. That's a massive undertaking. And it's a massive condemnation of just how weak and fragile our supply chains are. And this was before COVID hit. We were already in trouble. We were already having major problems. Next slide, please. Well, was COVID really all that serious? And the simple answer is yes. Everyone wants to talk about PPE, personal protective equipment. And yes, that was a disaster, an absolute disaster worldwide. No one could get enough PPE. No one had enough masks and gloves and gowns. But lots of other areas had a massive impact that had nothing to do with COVID. Over 1.4 million unintended pregnancies because we failed to get contraceptives to the people who needed them. Contraceptives have got nothing to do with COVID. COVID disrupted our supply chains so that we had all these excess pregnancies. More importantly, on malaria, It disrupted all of the anti-malarial supply. Estimated nearly 70,000 deaths because we failed to get anti-malarial medicines to the people that needed them because of the disruption for COVID. Malaria's got nothing to do with COVID. That disruption impacted the whole of our supply chain. And not just once. We had the first wave of COVID, and then we had the Delta, the second wave, and then how many more waves have we had of COVID going through the system? It was a massive disruption in areas which had nothing to do with COVID. And we must recognize the extent of that disruption. We must say, never again. We can't allow this to happen again. We can't allow one supply chain disruption to affect the whole of the public health medical supply. Next slide, please. If we look at the impact, and on this graph you can see this is from central medical stores in Africa. And by now, most are out of the top, the pink section, high risk. But this is HIV, TB, and malaria medicines. We're still in medium risk now today. We're in medium risk of out of stock of HIV, TB, and malaria medicines. This has nothing to do with COVID medicines. This is the disruption that COVID has caused to our whole supply chain. Our target for 2023, the WHO Afro target, is only 15% of countries will have a stock out this year. Only. ARVs, antiretrovirals for HIV, TB and malaria medicines, they're all life-saving medicines. How can we be out of stock? How is this permissible? But this is the impact that happened to the supply chain. We have to recognize this impact. And there are lots of reasons. Before COVID, we already had a shortage of medicines. Nothing to do with COVID, we already had a shortage of essential medicines. The USA listed 63 medicines which were in short supply globally. We've now got more than 100 medicines which are in short supply globally. We had the sheer volume of COVID commodities, all these masks, all these test kits, all of these gowns and gloves that we had to do. That disrupted our supply chain. Overall, we had a poor performance before COVID hit. We had virtually no resilience. How many of you even knew what PPE was 3 years ago? And we had virtually no pandemic preparedness. And we should have had it available. Next slide, please. Well, why weren't our supply chains resilient? Why have we had such a big problem? And largely, that's because we've had a lack of balance. There's a balance between efficiency and resilience. Generally speaking, as we become more efficient, we become less resilient. More efficient, just-in-time management. We have less buffer stock. We keep just enough to get by. We order just enough. That's efficient. It's cost efficient. It is not resilient. We increase buffer stock. We become less efficient, but more resilient. So there are competing claims on our operations. Efficiency to reduce costs, resilience so that we are prepared for disruptions. We've also allowed our supply chains to become globalized. Over the last 20 years, nearly everyone buys 90% of their pharmaceuticals from India, from a single source in India. And in India, it's around 6 manufacturers we buy all the pharmaceuticals from. That's globalization. That's massively reduced costs. It's made it more efficient, but it's reduced the resilience. When India went into lockdown for COVID, there's no supply. We are not preparing for disaster situations. We've had a warning. 5 years ago, WHO had the avian influenza pandemic preparedness. Every country, including Malawi, produced a plan for avian influenza awareness, a pandemic plan. Only 4 countries implemented the plan. Those countries had PPE. They had gloves and masks and gowns when COVID hit. Majority of us didn't because they didn't implement the plan. We're failing to plan. We've also got procurement systems which are frankly archaic. Many countries inherited them from colonial times. They weren't any good then. They weren't any good 70 years ago. And we're still using the same systems now, which are totally inappropriate for modern market conditions. We have to become far more flexible. We've become far too reliant on just a few suppliers, far too reliant on just a few sources, and we've got inflexible, highly bureaucratic, slow to respond systems. Next slide, please. Well, why did we allow this to happen? How could we allow efficiency to overcome the need for resilience? And I think the first point to understand is in 98% of cases, this was not a deliberate decision. Nobody sat down and said, we're going to become more efficient and less resilient. It wasn't planned that way. It was, in fact, inertia. Just ignore the situation. So what really happened is over the last 15 years, we've had a 5-fold increase in the volume of commodities that we're handling. 15 years ago, TB testing was a small box of microscope slides. Now we've got gene expert kits and we've got half a warehouse full of gene expert kits. TB treatment was a couple of bottles of medicine. Now we've got these great big boxes of kits. On vaccinations, the extended program of immunization had 8. Now we're nearly at 20. We've increased our throughput volume 5 times over the last 15 years. But we have not increased the funding into the supply chain, hardly at all. We're trying to do the same job with 5 times more throughput, with the same warehouse, the same trucks, the same staff, and the same funding. That makes us very efficient, but it makes us highly non-resilient. And that's largely what's happened. Our systems are not low cost by design. They're low cost because they're never funded properly. That makes them hugely cost efficient, but not very effective. Next slide, please. We've also allowed this globalization to limit us to just a few sources. Well, there's thousands of people make medicines, and that's true. But where do they get the API from? The active pharmaceutical ingredient. Let's understand that modern medicine manufacturing is really assembly. Pharmaceutical manufacturers don't make the API, they buy it. They don't make the gelatin capsules, they buy it. They don't make the excipients and the binders and the titanium oxide and everything else that goes into a capsule or a tablet. They buy it. What pharmaceutical manufacturers largely do is assemble it. Well, where do you get the gelatin capsules from? From China, because it's the cheapest place. There are pharmaceutical manufacturers in Malawi. Does anyone in Malawi make gelatin capsules? Does anyone make titanium oxide as filler for tablets? So all of this is assembly. So we've allowed this globalization. If you look at the situation of latex gloves, surgical gloves, they're made from rubber. But the particular rubber we use, 90% of it comes from one country, Malaysia. Why? Brazil makes rubber. Lots of countries make rubber. Why have we been buying latex only from Malaysia? This is the globalization of the supply chain. And the answer is because it's lowest cost. It's a lot cheaper. Most of you would never have heard of Wuhan 3 years ago, the place where COVID was first identified. Even now, not many people know that Wuhan is the center of API manufacturing in China. They make about 40 APIs for essential medicines. When they went into lockdown, there's no API. There's no active pharmaceutical ingredient to make the essential medicines. All the Indian manufacturers were buying their API from China, from this place called Wuhan, which they can't get anymore. No API, no pharmaceuticals. The same with the gloves and the latex, all from Malaysia. Malaysia's in lockdown. So our systems, almost by accident, without us realizing it, except for white-haired old professors, have become non-resilient, have become very fragile because of this globalization. This globalization has massively reduced costs. Medicines are much cheaper from India, and they're generally good quality, but they're not resilient. We have to think about resilience now on a global scale. Next slide, please. So post-COVID now, lots of clamor. Everyone is shouting, you must become more resilient. You must become more resilient. If you look on the internet, hundreds of publications saying the health supply chain must become more resilient. But as I look around, I don't see it happening. I don't see any more resilience. The sources of supply are not being diversified. We're still buying from the same manufacturers in India. We've said we must diversify. It's not happening. Emergency stockpiles, no, it's not happening. We might have a little bit more buffer stock than before, but it's really not happening. And we have to say, why is it not happening? Was COVID not a big enough shock to everyone? Next slide, please. So why are we not increasing resilience? One reason is people are dismissing COVID. It's as if COVID never happened. We have this management term. Those that have done management studies will know the term black swan. It's a very rare event. Most swans are white. Occasionally you get a black swan. So a very rare event, we call it a black swan event. And typically it only happens once every 100 years. So people are saying, well, COVID, it's not going to happen for another 100 years that we're going to get a pandemic like this. We can't spend money and time preparing for it. We just dismiss it. And the cost, resilience costs money. In fact, resilience is very cost efficient, but because of the way in which we look at the accounting, all they see is extra expense. And I want to introduce shortly the concept of Quali and Dali into healthcare accounting and explain how resilience really can be cost effective. It's because we're not including enough factors in the equation. We're just looking at the medicine price. We're not looking at not having the medicine. And I want to explain that. And all the other mitigating factors that we can do to reduce the impacts of these massive disruptions, to become more resilient, all cost money. It is cost effective, but it does need investment. Next slide, please. And the first one to realize is COVID was not a black swan event. We can't say it's never going to happen again. Our supply chains were already far too weak before COVID hit. COVID didn't produce many of the problems. It just highlighted the problems we already had. It brought them to the front. And COVID was not the first pandemic we've ever had. What about all the other pandemics? We needed major reform, major change long before COVID hit. COVID has really highlighted and given us the massive incentive to change. But we must not dismiss COVID as once in a 100-year event. It isn't. Next slide, please. If we look back, Hong Kong flu, 68-70, SARS, MERS, swine flu, Ebola, all epidemics, all happened. There's going to be another epidemic, I guarantee it. I don't have to be any great fortune teller to predict the future that there will be another epidemic. We've had epidemics in the past. We have not learned from them. We have not prepared. WHO made a major effort on avian influenza to get us ready. Every country invested and produced a plan. Almost no one implemented it. And if we had have implemented it, we would have been much better prepared for COVID. We have to understand the wake-up call that COVID has given us. COVID is not an outlier. It's just one more epidemic, and there'll be more to follow. We have to be ready for the future. Next slide, please. Okay, that's all very good. How do we achieve this resilience you're talking about? First, we need advocacy. We need to explain the problem, because many people are already dismissing COVID. It's over, it's done now, just get back to normal now. There is no normal anymore. COVID has changed the whole of the global supply chain. So first, we need to advocate. Anyone who will listen, we have to explain. Then we have to understand the fallacy, the falsehood of simplistic cost efficiency. It might look like it's cost efficient when you buy cheap medicine. It isn't. There's an old Russian proverb. We are too poor to buy cheap medicine. Because if we buy cheap medicine, it will cost us more in the end. We have to be able to recognize the true cost of stockouts. And what's the cost of a death resulting from a stockout? And that's the ultimate case on life-saving drugs. And we have to be able to use a risk management approach, a formalized, documented system. It's ISO system of risk management. We identify the risks and we try to mitigate them. We try to reduce them. So try to understand what's the cost of a stockout of a life-saving medicine. In the extreme case, someone will die. Well, what's the cost of a death? Well, there is in fact a way to calculate that. And we calculate it using a health economics concept called QALYs or DALYs. That's quality adjusted life years or disability adjusted life years. It's two different systems. They're similar, but a little bit different. In the private sector, the cost of a stockout is easy. It's the cost of a lost sale. I didn't make a profit, I lost profit. But in the public sector, it's denial of treatment, which is pain, suffering, possible death. How can you put a price on that? Well, we can, because we have this system of QALYs and DALYs. Next slide, please. Yeah, just populate all the screen, please. Yeah, good. Yeah. Okay. So this disability adjusted life years or quality adjusted life years. And I'll try and explain it like this. In order to save your life, I have to cut off your arm. And it costs $1,000. Is that worth doing? Well, if I cut off your arm, you might live for another 30 years. But you've only got one arm, so your quality of life will be reduced. So I might say your quality of life is only 75%. So I take those 30 years and multiply it by 75%, which means you would have the equivalent of 21 years of normal life. And then I take $1,000 and divide it by the number of years. That's about $50 per year. Is that worth doing? Well, most people would say, yes, that's worth doing. But now to save your life, I've got to cut off both arms. And it's $10,000. Well, no arms, your quality of life might be 50%. So you're going to live 30 years. 50% would make it equivalent of 15 years. 10,000 divided by 15, near enough about $800 a year, about quite expensive, but some people would say yes. Now, to save your life, I've got to cut off both arms and both legs, and it's going to cost $50,000. Now, your quality of life is very low, might only be 10%. So the 30 years at 10% becomes 3 years. Is this worth doing? And the answer for most people will probably be no. $50,000 for 3 years, it's very debatable. Yeah. So that's the concept of QALYs and DALYs. How good is your life after the treatment, and how long will you live? Okay. So if we look at some of our medicines and we look at antiretroviral medicines, the calculations for DALYs is it's about $350 a year. But you would have an almost normal life when you're on ARVs. You've got both arms, you've got both legs, you can do most things. Yeah. So that's quite a good value. But now we come to the reverse situation. What's the cost to the country of not treating this patient? If I don't treat the patient will die. And that's a cost to the country. Who's going to feed the parents? Who's going to feed the children? Loss of tax income. So the cost of not treating an HIV patient, they have calculated to be $28,000. Okay? Don't worry about the calculations. They're very complex. We can just look them up in tables. But those are the figures. The cost of treating, $350. The cost of not treating and the patient dying is $28,000. Okay? And we know patients die when we have stockouts. On the lower right, the box there for CART is from Côte d'Ivoire, Ivory Coast. They had 11% stockouts, double the risk of death. Double. So just having the stockout, the patient might not die immediately, but their risk of death is high. It's double because of the stockouts. So stockouts have a real effect. For life-saving medicines, they kill people. And that comes with a cost. Next slide, please. So what does this mean for PSM? Let's populate the slide, please. Okay. So if I take just the cost of the medicine, which is supply people, what we're interested in, first line ARV medicines are about $120 per year per patient. So the cost of having the ARV in stock on the shelf is $120. The cost of not having the ARV and the patient dying is $28,000. That means it's cheaper for me to have 200 patient years supply on the shelf expiring, not being used, than have a patient die. Now, I don't want it to expire. What I'm saying is this is the type of equation we need to consider. 200 times more cost effective to have stock than have a stock out. That's a massive equation, 200 times. Okay? So having buffer stock is very, very, very cost effective. even if you have a little bit expire. We don't want it to expire, we try not to, but we should be moving the risk away. We shouldn't be afraid of expiry. We should be moving the risk to be afraid of stockouts. That's the equation on risk management that we try and make. That's how we build resilience, by understanding the cost of a stockout. Next slide, please. Here's another example from the Philippines, a real case. They were out of stock for 1 month of TB medicines. 2,663 patients couldn't get their TB medicines. Around 63 people died. But these TB patients then developed MDR TB and transmitted it onto another 266 patients, who transmitted it onto another 588 patients. And the total cost of all this stockout with the extra treatment was $21 million. To be out of stock of TB medicines for 1 month. In effect, it cost $8,000 per patient to be out of stock. So holding buffer stock, holding supplies is really cost effective for a country. Next slide, please. So we have this idea of risk management. It's well documented. There are publications available to assist you how to get there, making this type of calculation, making this type of analysis. What's the risk? How can I manage the risk? How can I become better prepared? Next slide, please. So what does all of this mean? I've got to change the way I run procurement and supply chain. I've got to understand the risk. I've got to change the way I do procurement and the way I manage my inventory. I'm going to have more stock. I'm going to have more buffer stock. So I have to have better quality storage facilities and manage them better. Next slide, please. Well, that's all good, but I've talked about just an example on procurement, multiple sourcing. One of the ways we can do multiple sourcing is to make split tender awards. Instead of winner takes all 100% to the lowest bidder, I split the award. I might split it 80-20 for absolutely critical medicines like insulin for diabetes. I might do 60-20-20. And South Africa, all the UN, WHO has been doing it for years. Many in the private sector do it. So we split the tender award, but recognize there's a cost. Next slide, please. This is real figures from Uganda. On the bottom, you can see the lowest price I take as 100. The second lowest bidder, he was quite a lot more expensive. He was 60% more expensive. So if I made the award on an 80-20 split, that's 111.9%. We can say that's 12% more expensive. So I'm talking about multiple sourcing. And everyone's saying, yes, yes, you must do it. But the minute we do it, there's a cost. It's 12% more expensive. But there's less risk of stockout. One supplier defaults, the other supplier will come through. So this is the balance between efficiency and resilience that we have to come to. It's cost effective, even though it costs me 12% more to buy the same medicine, it's more resilient. And that's the kind of advocacy and explanation we have to make. Next slide, please. So, quick summary. Our supply chains were already weak before COVID. COVID is not a black swan. It's not once in 100 years. There's going to be another epidemic along in your lifetime. We have to get back to this balance between efficiency and resilience. Right now, it's all efficiency. And we have to prepare for a future of public health with massive changes, changing the way we do procurement, changing the way we manage and control stock. Okay, that's the end of my presentation. I'm a little over time, so over now to Dr. Joe Kalani for his presentation.
Thank you, Professor Andy, for your presentation. And now, before introducing Mr. Joe, I would like to introduce Mr. William. He is the president of Pharmaceutical Society of Malawi. William, if you can just unmute yourself and say a few words about our collaboration and just welcome the participants. William, are you there?
Yes, I am here. I was having some challenges with the network, but I think now I can be able to speak. So thank you so much, Prof. Andy. We are getting used and we are being assisted with your wonderful insights each time we have a webinar. Thank you so much, and thank you so much, Mr. Kalani, who is going to speak a thing or two soon. And thank you so much to all the participants, Sonia, for moderating on behalf of patients. Yeah, so our partnership with Empower dates back to 2020 or 2021. I'm not sure, but through the partnership, we have seen a good number of people from Malawi having access to the postgraduate diploma and also recently the master's degree. This year, we hope to explore more and grant the opportunity to the partial scholarship to more people from Malawi to pursue the postgraduate diploma and also the master's degree. On top of that, we'll have more of these webinars. We'll try to advertise in advance and also have physical in-person webinars. So please let us participate whenever we see the publication, whenever we see the adverts. And for any details, further details about PHASOM and Empower, you can contact me, especially those who are in Malawi. I will drop in the PHASOM official email in the chat box. Thank you so much. That's all.
Thank you, William, for your speaking. Now, I would like to welcome Mr. Joy Kalani. Mr. Joy, please introduce yourself by giving you a brief introduction, and then you can carry on with your presentation. Thank you. Mr. Joe, I can't hear you. Professor Andy, can you confirm if his voice is audible to you?
No, I can't hear either. Sorry.
Yeah. Mr. Joe, I think there is some problem with your mic.
Can you hear me there?
Yes,
Yes.
now loud and clear. Yeah.
Okay. I was saying welcome everyone to this webinar, and so many thanks to Prof. Anne for the wonderful presentations. Really has covered almost everything there is to know in as far as supply chain resilience is concerned. I am a pharmacist. I've worked in the various sectors in the supply chain, ranging from the hospital pharmacy, working in the wholesale pharmacy, and currently now working in the NGO setup, but really still involved in the supply chain. Prior to this, I mentioned I've worked with the Central Medical Stores Trust for slightly above 9 years before joining Partners in Health. My role this afternoon would not really be to go through what the Prof has already said, but I'll focus much in the local scenario. So we'll be trying to link everything that the professors said, link it to our Malawian scenario and see where and whether we are indeed that resilient or where are we getting it wrong, despite knowing that most supply chain are indeed not resilient. Next slide, please. Next. Yeah, so in terms of, just for the sake of getting to operate on the same level, we're looking at supply chain management. And according to ITCAN, it's a network of connected and interdependent, but also mutually cooperative, working together in order to improve the flow of materials as well as information from the suppliers to the end users. From that definition, we already see one major challenge is that there are so many players that are involved in the execution of that or in the management of the supply chain. And what that means is any slight problem at any particular point, it affects the whole supply chain. Next slide, please. So, because of the inherent characteristic of the supply chain that we have so many players, and therefore bringing in so many challenges, then now we bring in the issue of supply chain resilience to say within or taking cognizance of the environment in which all this is happening, how would we be now able so that to maintain our supply chain so that it is able to resist the disruptions. But again, in an event where the disruptions occur, we should have that ability of our supply chain to recover and return to the normal operations. Because we know that disruptions will always occur in supply chain. But the role, as the Prof has indicated, is that our supply chains should be designed in a way that we are able to forecast, anticipate, and be able to adjust accordingly based on the environment that we are existing in. So from the look of point of supply chain resilience, we are looking at two components. Resilience has got two components. And one of that is that it is resistance. It's capacity for resistance, which means when it encounters any supply chain shock, the impact should be minimal. So if our supply chain is able to achieve that, we say it has resistance, inbuilt resistance in it. But the other aspect is there will be situations where that resistance may be overcome. But after we've had that, the supply chain should also have the ability to regain functionality after such an event. So from that aspect, we are looking at resilience as the resistance, but also we are looking at the recovery. So in terms of resistance, then you will be thinking the supply chain should be able to avoid any potential shocks, or it should be able to contain such shocks. In terms of recovery, we are looking at when it has received, how long does it take to stabilize? So we are looking at stabilization of that shock, and again to return to normalcy. How long does it return to the normal operating environment? So from that, you see that most of the supply chain will range. You will still see supply chains that have the capacity to resist. So they have a high resistance capacity, but maybe in some cases you will find supply chains with a low recovery ability. So you will see that in most cases, institutions or supply chain institutions will have to make a choice in terms of how does it want need to operate. So whether you would be looking at a supply chain that will be will have a short or a quick recovery, but some will have a low resistance capacity, and those are the ones that we refer to as fragile. And this is unfortunately where most of our supply chain, more specifically the Malawi scenario is. Because looking at the setup in our supply chain, you'll find that even this smallest shock is able to affect, to disrupt the whole supply chain. And now when it is disrupted, you'll find that even our level or our capacity to recover is just so slow. And that makes it very, very, very much fragile. Next slide, please. So there have just been so many strategies. I think the prof has mentioned most of these. What are the strategies that have been in use over the years? Because these are not new strategies. They're just old strategies that have been there. I think the difference has been how different supply chains entities have been able to implement them depending on the things that they see on the ground, or the different factors that they consider as critical. So in terms of the first strategy is to optimize production with supply chain planning. We all know the importance of supply chain planning as it promotes visibility, it promotes agility, but it also provides a better understanding of supply and demand. And because of that, the better understanding between supply and demand provides an opportunity that supply chains can limit disruptions. We've talked about the supplier, the prof talked about supplier diversifications. We can also talk about multiple sourcing, which is more of theoretical, that people talk about it. It is there in the literature, but when it comes to the practical aspect on the ground, so little on the ground. And that's the same situation for the Malawi situation. When you look at the nearshoring, it's just trying to bring closer our sources. So instead of getting all our sources from China, India, then we're looking at, can we think of nearby, what are the alternative sources that are close by within the region that we could still get the same products at this of the same quality, because this has got an impact in terms of how quickly we recover from any shocks. We can't talk about more on the COVID because I think for Malawi, we cannot really say it was due to COVID, because I think the supply chain has been very fragile, maybe for over 10 years or so. The other strategy that is employed is the inventory and capacity buffers, which I think the prof has also talked about. Here is where we build in buffers along the supply chain. The anticipation is that should there be any shocks, these buffers should be able to take us a little while as we try to recover from such shocks. All this, when you look at all this, the most important thing, or the fuel that will really provide all that, is the data. Do we have the data that will be able to inform the decision that the supply chain decision makers will make along the way? So we are looking at systems to have the ability to analyze, make sense of the data, use it for decision making, together with the risk mitigation framework that most supply chain organizations will have, so that we together, the decisions that are made do really respond to the situation on the ground. Next slide, please. So the question that we have is, where are we as Malawi? Is Malawi supply chain resilient. From what we've learned and from experience, we all agree that Malawi supply chain is not that unique. It's not resilient, just as most of the supply chain. We are so fragile. In terms of our vulnerabilities and in relation to COVID-19 pandemic, I agree with the professor that the COVID pandemic only exposed our vulnerabilities that were already there. We already knew what our challenges were, because stockouts in Malawi, it's not a new thing. Most of us, we know. We may have explanations, different explanations as to why stockouts happen, but it also it just emphasizes or pinpoints the fact that our supply chain, the healthy supply chain, is so vulnerable to any slight shocks. When we talk of the shocks, you agree with me that a mere and unexpected increase in consumption does affect the whole chain, because the system is not made to respond to such changes. Why is it so? You will find that we don't have real-time capturing of data that will now inform to say, what are the trends that we're getting on the market? What we need to do to respond to these trends. As a result, those red lights do not come up until it is too late. So such kind of things make it our supply chain very vulnerable. But the most important thing, as we've talked about, if we are to achieve resilience, then you need resources. When you look at the funding for the supply chain as a whole, and here I'm talking about supply chain as a whole and not just the famous drug budget that we talk about, because one of the things that people tend to forget is that supply chain has a cost. And that cost is normally in our setup forgotten. And people talk about our MPs, our politicians, who talk about the drug budget. We've allocated so much for drugs. But what they forget is that the logistics or the supply chain costs can consume up to 25 or 30% of the total costs. And that is a substantial cost to be just left to chance. And this is a clear manifestation that if we are really to bring a clear evidence that if we are really to come to and have a resilient supply chain, then we should have adequate funding that would really be will have the capacity to put in the necessary shocks that we're able to respond and to such trends. Another factor that I would want to discuss, and it has also been mentioned by the previous speaker, is the effort, or whether it is deliberate or whether it is unintentional, the desire to adopt the just-in-time philosophy in our setup, which has got a lot of challenges. There is that belief that inventory, or that common say that inventory is evil. So the question that I'm bringing is this by design? Is our system designed that we should check, it should have just in time? Because I believe the supply chain system is by design designed to produce a certain result. And when it produces that result, we all know to say this is what it was designed to do. But in our setup, when you compare how the supply chain in Malawi was designed, you'll find that in terms of from the lowest health center level, healthcare level, I'll take for example, the health center. The guidelines will talk to say the health center is supposed to have a minimum of 3 months inventory. And then when you go to the regional, you will be talking about keeping at least 6 months worth of stock. And then when you go to the central level, we are looking at more than 1 year. Now, when you combine that, you find that the system was designed to keep not less than 18 months of stock. But is it what exactly is happening? The answer is no. But why have we done so? It's because of the previous reason that I gave in terms of underfunding. Because the funding that is made towards the medicine budget, you find that it is not even adequate to cover for just a year. In most cases, it's probably half of the total requirements. And that makes it even impossible to think of building in buffers within the supply chain that will be able to cushion in terms of any supply chain shocks. Next slide, please. Next slide, please. Right. When we talk about diversification, indeed, in Malawi, the Prof mentioned that we have factories in Malawi, local manufacturing in Malawi, and the government has made efforts to put in some incentives to encourage local production. And that is a positive thing. The aim was we will see a shift in terms of where we get most of the sources. But the problem still comes, as already mentioned, that these are suppliers that are manufacturers. We call them manufacturers, but when you look into what exactly they will do, you find that everything is imported, right away from the API to the packaging material. Probably it's only the labor that would now be talking about being local. So in that situation, anything that happens outside can also or ends up affecting the local production. So again, despite having that initiative, it really doesn't give us any advantage in as far as resilience is concerned. But again, we talked about the regional manufacturing. As a country, we haven't had that explored that option of seeing where can we get our alternative sources for these pharmaceuticals. And we all, when it comes to sourcing, it's the same scenario where we're looking at India, we're looking at China, and these the examples are so many. And whenever we are hit, we couldn't even have even a simple Panadol, a simple aspirin. We couldn't because all our sources are coming from India, and that had an effect on our supply chains. The procurement law, as has been highlighted by the Prof, in our setup, the procurement law is a winner takes all, and the risk is, as already explained, the risk is just so enormous because the supplier, if the supplier defaults, then you have nowhere to go. You have to start the process over again. Our lead times are very long to the extent that when you are to start over again, our lead times is about 6 to 9 months. And that is a long period. And should a supplier default, the impact on the supply chain is so enormous. And again, we've talked about the importance of data. As the fuel that moves the supply chains, our systems are generally manual based, and it makes it decision making very difficult because one, the data is inaccurate, and again, it's cumbersome to process all that data. It is not real time, and all this contributes to the uncertainty that we have, or in terms of our capacity to make our supply chain resilient. Next slide, please. But having understood all these, what needs to change? I've just put a few. I know there will be so much that would have to change, but I'm saying we need to embrace a digital tool to collect, analyze, and utilize the data for decision making. It is only through that if we make that real time, the data comes in, and we're able to analyze constantly and be able to proactively take action based on the trends that we're getting. We'll be able to at least, we may not talk about resistance, but we'll be able now to react and to proactively act so that we are able to prevent some of the shocks that would befall on us. The next one is invest in supply chain to improve its resilience. We need to invest heavily, not only in terms of resources for the procurement, but we're looking at the infrastructure that will enable, if we're looking at buffers, do we have adequate infrastructure that we need? When you look at storage spaces, we have the storage spaces that will be able, if we bring in much needed buffer stocks, do we have the storage space? So we need to invest in the supply chain in its entirety. But again, reviewing the procurement law to allow at least the second and third lowest evaluated bidders. I know it is happening in some countries. The prof has mentioned of Uganda. We know India uses a different law together. If India uses 50, 30, 20, just to be able to cushion itself that for those that can be prevented, the supply chain shocks that can be prevented, we are able to prevent loss. Next slide, please. So in summary, we were saying the COVID-19 pandemic only exposed supply chain vulnerabilities that were already in existence. There was nothing that we didn't know. We already had stock out. Only that probably this just gave a new explanation, a new excuse, but we all know that our supply chain hasn't been resilient all along. The Malawi health supply chain was designed with some resistance in it, inbuilt resistance. When you look at the buffer stocks that were built into the system, that was meant to at least be able to resist some of the shocks. But somehow along the way, we lost due to pressure to adopt new technologies without really testing them to see whether they really work in our environment. Issues of resources made it very difficult to implement, despite having a well-designed systems that could offer some supply chain resilience. A review of the appropriate sections of the procurement to assist in the mitigation of some of these shocks. And that's my last slide. Thank you so much for the attention. Over to you, the coordinator. Thank you.
Thank you, Mr. Joe, I'm so sorry, for your presentation, and Professor Andy. Now we will move on further. There are two slides. Basically, I would like you all to just have a brief information about the Empower courses that we offer. As you can see, we have recently launched a master's course in global health procurement and supply chain management. We have two categories under this course, 12 months and 24 months. Then we have PGD course that is for 12 months and 6-month diploma course, and there are multiples of certificate courses. So for more information on courses, I would request you all to please visit our website. Over here, I would like to just, as explained to you, there are two categories under master's course. That is, one is for 24-month course. This is eligible for all. 12-month master course is only eligible for the PGD graduates. Those have their graduation from Empower School of Health. And the PGD course fee you can see over here. This is 2,500 USD, but these are the initial fees. We have some partial scholarships also. So for more information on this, as mentioned by William, you can get connected with PHASOM by William, or you can get connected with us. The process for applying for partial scholarship program, you can write an email to me. The email ID is mentioned over here, operations@empowerschoolofhealth.org. Then all application will be reviewed by Empower School of Health. Selected applicant will be informed. Selected applicants will then be informed of the application and registration process. And for detailed information about the courses, this is the link which we have mentioned over here. You don't need to worry. The slides will be shared with you all post webinar along with the recording link. Now we will just move on there. Now it is the time to launch poll 2. I would request my backend team to please poll launch 2. This is the last poll, so I would request all participants to please participate in this poll. There are basics 4 questions, so you, in the same way that you have participated in poll 1, in the same way you have to participate in this poll also. So as you can see, I would request participants to please select the respective answers. We don't have much time. We also left with Q&A session. So also please be ready with your questions. We will pick few questions and those will be addressed by the speaker. So the first question is, what percentage of information was new to you? The second one, after this webinar, would you like to enroll in the courses? Then third, how did the sessions compare to your expectation? And the fourth question is, how likely are you recommended this session to a colleague? So I can see people are still voting. Only 37% of participants have been participated. We will wait for a few more seconds and then we will stop the poll. 50% of participants have participated, so it means 50% more has to be participated. So I would request all to please participate in this poll. This will help us to know your feedback. Basically, this poll is a feedback of yours, so it will help us to improve in our upcoming webinars. As informed to you, the slide deck will be shared with all, the recording link will be shared with all, and also you can check the recording as this session is going live on our Facebook page. So you can also see our recording over there. At the last, after Q&A session, there will be a link that will be posted on the chat box. So which you can fill up by yourself, and the participant certificate of the participant will be sent to your registered email ID, which is registered with us. So now I would request backend team to please launch the poll and share the results. Yeah, so I can see what percentage of information was new to you. So 5% says 100% and 61% says 50 to 75%. Okay. After this webinar, would you like to enroll to the Empower School of Health courses? Yes, 71 for this. I would request you to please get connected with me on the email ID that is mentioned on the last slide, which will be posted on the chat box also. Was the session compared to your expectation? 59 says excellent, 41 says good. And how likely you recommend? That is 8 to 10. Thank you so much for your participation. Now we will move on to Q&A session. So Professor Andy and Mr. Joy, I would request you to please pick up the question as per your convenience, and if you can just answer a few of them.
Okay, so perhaps if I start, we had a question about DALIs and QALYs. These are very complicated. Normally, we as supply chain don't calculate them. We just take the reference from the health economic tables. It really is a major activity to calculate them. It's a case of being aware there is a way to measure the impact. We don't have to make a detailed calculation, just reference it. You'll find plenty available to you on most areas. Major problem in supply chain is lack of visibility. Yes, I would agree with you. The WHO Good Governance Program is an excellent one to follow to increase visibility and go along with that. How do we come out of stock conditions? How do we overcome out of stock? We become more resilient, of course, more buffer stock, more planning, risk management, and risk mitigation. Key tools for resilience, risk management. I gave you 2 references from USAID. There's the whole ISO program of risk management. We must introduce that into the supply chain. Multi-sourcing is only theory. Yes, it is. Largely, we have to change the way we do procurement. We need massive reform of our procurement system. KPIs for resilience, yes, use the maturity models. There are 2 major different maturity models. Doesn't matter which one you choose, use the maturity models. You'll find the KPI for resilience there. When can we say we are resilient? When you can handle a stock out of more than 6 months. When you can handle a non-supplier, supplier default of more than 6 months. You should be on the path to resilience. What can we do for transport when they close the country borders? We have different options available. We have stockpiles available. That's what being resilient means. Having alternative sources of supply available, not just land transport. So we've got air transport, we have got stockpiles in country. Okay, that's me done. I'll hand over to Dr. Joe there, see what he feels on the questions that are in the pot.
Thank you. I've gotten, I think you've answered most of the questions, but I think there was one on corruption, in the impact on corruption in terms of resilience. I would say in terms of corruption is indeed evil, and it does affect how the supply chain operates. However, in terms of direct linkage to resilience, we know that corruption ends up draining up the resources that could otherwise be invested in the supply chain. So from that perspective, we see that corruption would indeed have a negative impact on the resilience because of that very particular aspect. And those ones, I think, would be really relying on good governance, as has already been mentioned, that it will go a long way in terms of addressing that. Thank you.
Okay, I see we've got one hand raised from Hassan Abdi. If you'd like to ask a question, please go ahead. Okay, or type it in the chat box. Okay, otherwise, Sonia, I think we're out of time. We're already quite late.
Yeah, it's almost 30 minutes that we are over to the scheduled time.
Yes, okay.
So, yeah, now, so I would request my backend team to please put the link to for the certificate on the chat box. And I would request all other participants to please download your certificate. And for any issue related to certificate, you can get connected with us. Thank you so much, Mr. Joy. Thank you, Professor Andy, as always. You're always a good help. Just last few words from your side, and we will close the session. Thank you all.
Okay. Bye. Good night to all.
Bye to everyone, and thank you for your attention and participation.
Thank you, Mr. Joy. Thank you, PHASOM. Thank you, William, for your support to make this event successful. And we will look forward for more such events, as you mentioned, virtually and physically this year. So we would be able to be more interactive with the audience from Malawi in that reference. And for all the upcoming webinars, I would request you all to please visit our social media page. Everything is posted over there related to us. Thank you all.